Okay, good morning, welcome back. I am Lee Gervitz. I head up medical for Biogen North America, and I am thrilled to be joined today by Dr. Brent Forrester, who is a leading expert in the field of Alzheimer's disease and the chair of the Department of Psychiatry and the interim chair for the Department of Neurology at Tufts Medical Center. As you heard in the last panel discussion, the ability to treat Alzheimer's disease is rapidly changing, and that brings associated changes to our overall healthcare system infrastructure. And Dr. Forrester is very much at the forefront of establishing new care pathways to treat people with Alzheimer's disease, and is going to share some of his insights in terms of how the healthcare system can adapt to help best support the individuals and the families that are impacted by this disease. So Dr. Forrester, thank you so much for joining us today.
Thank you, Lee.
I thought maybe we'd start off with kind of what is today's environment. If we're thinking about, we know the field of Alzheimer's disease has been evolving, and changes in treatment options often bring change to how the healthcare system works. Maybe you could start off by giving us a sense of how is the diagnosis of Alzheimer's disease confirmed today, and how long does that process take for most patients?
So first of all, thanks for inviting me to be here today, Lee and others. You just heard from a wonderful expert panel, and I think they addressed a lot of these questions. So maybe what I'll do is try to augment and not repeat what was said. I agree with everything that panel said, with a few caveats. So I'm a geriatric psychiatrist by training, and I want people to understand that there is no field of dementia care like there is a field of oncology. And this is one of the problems that I think we have in scaling the expertise that we need to reach a larger population. Also, the three fields that really are expert in dementia care, neurology, like you heard from Garrett, geriatric psychiatry, and geriatric medicine. These are the three fields in medicine that are trained to evaluate and treat people with dementia on the medical end. We don't always see dementia in the same way. In some ways, it's like you look at an elephant and you look at the tail and then you see the trunk, and then who puts it all together? So I think it's really important when you think about evaluation and treatment in a specialty center like the ones you heard about this morning, or ours at Tufts that we're evolving, and others in other systems. An interdisciplinary team approach is really critical. And that team approach doesn't exist in a way that will allow us to scale the assessment and treatment of people with cognitive problems in the way that we need to, given the numbers that you just heard. And that's why there's a delay in diagnosis, at least on the healthcare front, and long waits, is because we just don't have enough volume of clinicians. We really need to change the paradigm of how we identify and treat people with dementia, and that really starts in the primary care setting. And when I say that, I get anxious, because my colleagues and friends in primary care are overwhelmed and overburdened with being asked to be the fulcrum for all of what's wrong with healthcare. They're being asked to fix problems with heart disease, diabetes, cancer, behavioral health conditions like anxiety, depression, substance use, and dementia. So the only way to really do this well is to really integrate some of the expertise that those of us in the specialty world have within the primary care setting. And I know you're going to ask a few questions about that, Lee, but that's one thing I would say. The second thing is, in addition to the delays in diagnosis because of access issues, there are a lot of other reasons why there's a delay in diagnosis. And a lot of that has to do with our own reaction to aging and our own feelings about loved ones who are developing memory loss, or even the person who is developing memory loss and cognitive problems and how they perceive that themselves. So, for example, we see aging parents or an aging loved one, and we're like, it's normal aging that they're forgetting where they put their keys, or they can't remember what we just talked about. And how do you tell the difference anyway between normal aging and a more serious condition like dementia? That is difficult to sort out without a more careful assessment. The second thing is the defense mechanism of denial and minimization. There's a lot of fear involved in this diagnosis. It's a dreaded diagnosis. I tend to look at the world as half full, not empty, so I'm way more optimistic. I tend to think about what we can do for people with this illness as opposed to what we can't do. And so that perspective, I think, informs my approach to why it's important to diagnose early. But that's not the reaction of most people when they're confronting a reality of a loved one who has a memory problem.
Thanks, Brent. I think out of that, I mean, maybe we can dive in a little bit of, you were talking about how care models and you're looking at what's happening in the primary setting. You recently published in JAMA Neurology a really wonderful perspective that was looking at an article describing kind of that collaborative dementia care model. Maybe you could dive into that a little bit, and what do you see as some of those key features of that model, and what are we learning from other therapeutic areas that you would say could apply in the care of dementia and Alzheimer's?
So a lot of what we learned about care models for dementia really came out of care models for depression that began over 20 years ago. And at the fundamental core of this is the problem that there are, as you heard in the last panel, there are never going to be enough experts in geriatric mental health care, dementia care, et cetera, to care for the population in need. So I've spent a lot of the last decade of my career working in research and in clinical settings and across healthcare systems to develop and implement integrated care models to scale the expertise that we have. Not a day goes by or an hour goes by where I'm not getting called by a family or friend or somebody to help out with a behavioral health or a dementia condition. And I do what I can do, but it's not an effective way to provide care. And unfortunately, a lot of that happens today. So in terms of the care models in the article, Lee, that you were referring to, there have been a number developed over the last 15 years that have demonstrated when you pair a nurse practitioner along with a social worker, supervised by one of the dementia expert physicians, and plug that group into a primary care setting, you reduce emergency room visits that are unnecessary, hospitalizations, you reduce the caregiver's burden and distress, you improve the quality of life of the person with dementia, and you reduce overall healthcare spending. It's what we would call, so there are a couple of models that have been developed. One that we wrote about in this particular piece is called Care Ecosystem. Care Ecosystem was developed by colleagues at UCSF, and it really is trying to get people to function at the very top of their license, which means you can train non-clinician coaches or dementia care managers, if you will, the topic that the term that the Alzheimer's Association is using in a lot of their literature now are called dementia care navigators. But these individuals, again, college graduates, are trained to collect some of the data you heard about before: cognitive assessment, functional assessment, behavioral assessment, getting the history with the family, pulling that together with a social worker and a supervising physician to help make and communicate a diagnosis, and then support the family throughout the journey. And we could talk more about how that would fit, not just in a primary care setting, but could also fit as we start to treat people early stage with some of these new disease-modifying therapies, so that we're not just giving a biological intervention, but we're wrapping holistic dementia care around it as well.
And when you're thinking about bringing in those kind of changes into a healthcare system, there's going to be steps that need to be taken that are critical first steps in terms of establishing that. Maybe you could give us a little bit of sense of any place that would want to be implementing this. What would be those first few 2 or 3 critical steps they have to get aligned on?
I think it's such a great question. This is what a lot of us have been struggling with. How do you actually implement what we know works in a healthcare system that's not ready for this? So one of the problems with these care models is, until recently, there was absolutely no way to pay for them. There was no funding mechanism through commercial or federal insurance to pay for a dementia care ecosystem, if you will, in primary care. The first thing I think you have to do, number one, is you have to demonstrate a financial model that could work and get buy-in from senior leadership. And how do you get buy-in from senior leadership on anything? Well, you need a financial model, but you also have to show why this matters. And one of the things that matters to leaders of healthcare systems, especially in our state, where we put a lot of value in what we call value-based care or population health, where we're not just caring for the individual in front of our eyes today, but we're caring for an entire population in need. One of the things that gets their attention is performance on our risk contracts with insurers. And the performance is based not on how much we do and how many patients we see and how many procedures we do, but it's really based on the outcomes of our patients and the utilization of healthcare services like the emergency room or unnecessary hospital days. And if we can demonstrate value in terms of the outcomes on those contracts, as well as the clinical improvement of patients and their families, that's the story that I think we have to tell. And unfortunately, there are not many people in healthcare systems who come with both the expertise of having worked with this population and the knowledge of population health and value-based care to make that story come alive. All of this hopefully will change with the advent of the CMS program, the CMMI, which is our innovative payment mechanism through CMS, that was launched last July. It's called GUIDE, the Guiding and Improved Dementia Experience. This is an innovative payment model. It's an 8-year demonstration project by CMS. A number of our centers in Boston applied. We applied. We're going to be a center for this. 400 around the country are going to be centers for this. And essentially what it is a new payment mechanism to deliver that integrated team model-based care, delivered either in a specialty memory clinic setting or even in a primary care setting.
And I think if I'm thinking about that and saying there's that at the implementation phase of that, for that to work at its best, you're going to have to be improving what's happening in terms of timely diagnosis of Alzheimer's. So maybe if you can give us some sense of where do you think we are today versus where you'd like to see us in the future in terms of, we know early detection of AD can result in better outcomes. So where do you feel we are today in terms of advancing the detection and diagnosis? And where do you think we'll be in the next 2 or 3 years?
So you heard a lot about where we are today. Whether it's in a primary care setting or in a specialty care setting, we over-rely on outdated tools that are often being implemented too late in the disease process. You know, we don't have the type of screening tools, either a cognitive assessment, a functional assessment, or a behavioral assessment that can be collected in real time and help with diagnosis and prognosis, as we do, for example, with a lot of tests that we utilize all the time for heart disease and cancer. Well, you heard earlier about the use of AI tools in terms of digital neuropsychological assessment, whether it's voice or auditory or some of the AI tools used to augment some of the tests on the MoCA that you heard about with the clock draw. If you draw the clock onto a digital device, you learn way more about cognition than just watching someone write it on a piece of paper. Digital neuropsychological testing combined with careful clinical assessment together will help us to recognize some of these very subtle issues before they become obvious problems. So that's one thing that's important. The other is we don't yet have ready for prime time in the clinic blood tests that tell us what's going on in the brain. We have amyloid PET scans, as you heard about. We have MRIs to look at the structure of the brain. We now have in research settings that could be utilized clinically, but they're not quite ready, blood tests. And these blood tests reflect amyloid and tau buildup in the brain, which are the 2 hallmarks of Alzheimer's disease. And we're seeing data from the research world that those biomarkers from the blood are highly correlated with these brain scans and with these lumbar punctures when we take cerebrospinal fluid in an LP, a lumbar puncture. And as they become more reliable, frankly, and valid to use in clinical settings, we're going to be able to pair clinical assessment, as I just described, with those blood-based biomarkers to make diagnoses earlier. And if those biomarkers are now also in the hands of primary care clinicians, that also can help with early diagnosis. But one caution, what I'm really worried about is they're going to be over and under interpreted. The results of those tests, if you were to go ask your doctor for one today, you could pay for one of these tests. They're commercially available. They're not yet FDA approved or paid for. And if you were to get one of these tests and have evidence of amyloid in your blood, which means you have evidence in your brain, you need someone who's a clinician who understands this illness to interpret what that means. And there could be a lot of false reassurance if they're negative, and a lot of false angst and worry if they're positive. And I will just warn all of you to just be very thoughtful as these new tools, these blood-based biomarkers come into the market, that we are very careful about how we interpret their findings, and that they're interpreted in the context of a careful clinical assessment.
Maybe talking a little bit more about those blood-based biomarkers. If you're seeing, tie that to the care model that you're talking about implementing, and you're seeing a navigator coming into space, where do you see that biomarker playing into that? Is it at the primary setting, more at the specialist setting?
So I think if you pair a navigator and one of these care model teams assessment who are doing a clinical assessment with a blood-based biomarker, and you have a team talk about what that finding really means, it's a way to guide people into appropriate treatment early. So for example, you might have somebody who right now in primary care, and I left this out of your last question, but right now in primary care, there is an annual Medicare wellness visit that does include a cognitive assessment. How often it's done, I'm not sure. How much follow-up there is when it's done, not great. And part of that problem is primary care just doesn't have the time or equipped with the resources to know what to do with a positive finding. But if you pair that clinical assessment, including a cognitive screening, systematically in a primary care population of people 65 and above, you're going to find people then with a biomarker that's positive who are appropriate for these new treatments before they would ordinarily just present because they were worried about their memory. There has to be some systematic effort at early detection. And so if you pair the care navigator assessment with a blood-based biomarker and have a thoughtful discussion about the meaning, that's when you can, I would call, triage people into various levels of care. As some people may not have any evidence of illness in their brain, and there may be another cause of the cognitive problem like depression or anxiety or sleep disturbance or alcohol use, et cetera. All of that is part of clinical assessment. But there may be others where you've now detected somebody with the earliest stages of Alzheimer's disease in the mild cognitive impairment stage, and they may be a candidate to be further evaluated, so that these specialty clinics are not overwhelmed and inundated with folks worried about their memory who are fine, but rather are getting the right kinds of patients who may actually benefit from the treatments, and that will reduce the wait times.
And I think now that we're seeing is where you are at Tufts and the changes you're starting to implement there and how you're seeing in terms of that model evolving for you, how do you see that shifting? I mean, what challenges are you facing now in terms of folks that are coming into specialty that how many of them are you seeing success in terms of coming to you early enough versus are they coming to you too late in their journey?
So when I think about building a memory center of excellence, let's say, in a health system like where I am at Tufts, I thought of it really with 4 different parts to it, okay? One part to it is the core specialty team, which we talked about, the interdisciplinary memory clinic team that has psychiatry, neurology, may have geriatric medicine, certainly has social work, critical, nurse practitioners to augment our availability, and neuropsychological testing of some kind, along with imaging, et cetera. And that can help with diagnosis, et cetera, and guiding people into treatment pathways. But again, that's going to be available for only a certain percentage. And I would say, to answer your question, 80 to 90% of the people referred into those clinics have an acute problem that are bringing them to attention. It's obvious there's a safety concern because of cognitive problems. Or, more commonly where I am, there's a behavioral complication like depression or agitation or paranoia, which, by the way, those behavioral and psychological symptoms are really what drives this disease burden in the first place. So it's what burns out caregivers. So if we could, so we have the interdisciplinary memory clinic, and then a portion of those people will meet criteria for being probably benefiting from these disease-modifying therapies. So the second arm is the ability to stand up a clinic, including an infusion center, that will be able to safely deliver these treatments that have side effects, including brain swelling and brain bleeding, that we have to monitor for really carefully. These are not easy to implement interventions. So the specialty memory clinic is one piece. Guiding people into new treatments is the second. The third is the primary care piece we just talked about, using the integrated care model team. The other piece that a lot of people forget about, but our state is a real leader in this area, and I give former Governor Baker a lot of credit, in legislation passed in the state in 2018 that he signed into law. One of the provisions of that dementia care law included that every acute care hospital in our state has to have a dementia care plan of approach for people showing up in the emergency room and on the medical and surgical units. And how many people, your loved ones, have, let's say, surgery for a hip fracture and get very confused and agitated? And many of those people, you didn't know had a cognitive problem, but they actually have underlying dementia. So in our system, we're also building in an appropriate assessment and a care pathway for managing people with dementia when they show up in those acute care settings. So those would be the 4 pieces.
Okay. I know we're going to be kind of starting to run out of time a little bit, but out of those, I want to take the last few minutes to really think about, put yourself into really the aspirations for the future. And I'd love to get out of all of your experience in treating AD, what are you seeing as your deepest aspirations for what the future of Alzheimer's care delivery is really going to look like?
Well, there's the aspiration and then how do we get there issue.
Yeah.
So one of the how do we get there issues that I really wanted to highlight. So a comment made in the last panel was about comparing where we are in dementia care with cancer 40, Garrett I think said 50 years ago. I usually say 40, but it's somewhere around 4 or 5 decades ago. And one piece of that, it's not just the diagnostics and the therapeutics, but it's also stigma. Okay, I would say the most important thing we have to eradicate is stigma.
Yeah.
One of the reasons why there's minimization denial is fear of the unknown, fear of this disease, and the inability and the unwillingness of people to talk about it. And I still hear physicians saying, I don't feel comfortable making that diagnosis. I still hear physicians telling a family member because they don't feel like they're comfortable telling the person with the illness. That's what we were doing with people who had cancer in the 80s and 70s. We have to change that. So that, to me, that is like critical. And I give the Alzheimer's Association, I give clinicians, researchers, pharma, biotech, all together working to break down stigma. And trying to approach this disease as, number one, it is so common that there's not a single person that I know that doesn't have a family member or a friend with this illness. This is not unusual. This is extraordinarily common. So that's one thing, is breaking down stigma in education. The second is we really have to change the way we prioritize the care of aging. Aging, period. Yep. Some, but not all of which, is dementia care. But that is a big piece of it. So our healthcare systems need to reorient themselves to geriatric care systems, because that's essentially what they are and will increasingly become. And a big part of that has to be early diagnosis and recognition of dementia, getting people into the appropriate pathways. And because dementia is a family disease, supporting the family has to be part of treatment. When I see patients with dementia, I see the whole family. I don't just see the person with the illness. When possible, I see the family. And without the family, there's very little I can do as a singular clinician. So I think it has to be seen and approached as a family illness, not just in our homes, but in healthcare as well.
So that's how we'll get there. Where do you see it in terms of where do you hope we're going to be? Your aspirations for 5 years from now? How much has the system shifted?
I would love to see the availability of screening and assessment and support for the primary care's communication of diagnosis and conducting the appropriate workup as a standard part of primary care. There's no way, if we rely just on the specialists, the access problem will just grow. So I think it has to start there, but it can't be on the backs of them without the resources within the practices to support diagnosis. I think the biomarkers, whether they're blood-based or others in the future, the digital biomarkers, the blood-based biomarkers, together with clinical assessment, will help us to make earlier diagnoses. And then every family member deserves someone, like colleagues I've worked with over the years, who are genius at helping families throughout this journey. We will save so much emotional distress, unnecessary medical burden in caregivers if we can intervene early on in helping them navigate this journey. This takes time, it takes energy, it takes a ton of resources. And so I would love to see a world in which a lot of these dementia care resources are available within primary care. I would love to say we'll have more specialists, but I've been trying for 30 years to get more people into my field. It's been a mission, and in the United States in 2024, we're training 50 new geriatric psychiatrists like me a year. That's it. That's not going to work. It has to be a team-based approach, and it needs to really have people working at their top of the licenses as a team.
Well, Brent, thank you so much for putting all of your passion, commitment, and making a difference for this community and for these patients. Thank you again for joining us. Stick around for more sessions, and today is the future of medicine.
Thanks, everybody.